I want to talk to the students about my personal journey in transplantation as an example of how to marry clinical work with research and a full life. So this is a picture of the Detroit Art Institute, and this is a mural by Diego Rivera, who's a famous revolutionary as well as a famous artist. And you can see the images of women at the top. This is his depiction of Mother Earth, and this was somewhat inspiring to me as a child. But as a child, my mother used to take us to the Art Institute, and we also used to see images like this that are so amazing and kind of frightening. I started my career in undergraduate and then for medical school going to the University of Michigan, which is a fantastic institution. At the time that I started medical school, 20 of the 220 students were women, and of course we felt somewhat alone. At the University of Michigan, I got inspired in the field of transplantation, which was a relatively new field at the time, and I decided to go to the University of Minnesota for my training, where John Nigerian, who is pictured here, was one of my mentors, as was Fritz Bach, who's a basic scientist, and Richard Simmons. And at this institution, which was one of the pioneers in transplant, I cut my teeth on doing transplantation. When I stopped my training as a young faculty, Dr. Thomas Starzo offered me a job, but although I decided to not work with Dr. Starzo, I decided that I wanted to do liver transplant anyway. And so I was somewhat self-taught doing liver transplant and started the program at the University of Minnesota. This is my love, the liver, and this is a cirrhotic liver for those of you who have not been in the operating room too much. This is a photograph of a recent transplant. This was taken by one of the photographers from National Geographic when he came to visit us in the early 80s to watch us do liver transplants. I left University of Minnesota, where I was a young faculty, and went to the University of California, San Francisco in 1988 to start the liver program there. My boss was Haile DeBass, who you can see on the right side. And UCSF is a fantastic medical school and a fantastic place for research as well. One of the first projects that I got involved with relates to liver transplant rejection. We were the first group to actually describe the histologic manifestations of liver transplant rejection, which you can see there. And we worked on the mechanisms associated with the expression of class 1 and class 2 antigens, which are rich on bile ducts and relatively pos, not very rare on hepatocytes. And that reflected the fact that the inflammatory response was around the bile ducts. Another project that we worked on early on related to fulminant hepatic failure, which is the sudden onset of liver failure, frequently in normal individuals. And we showed that if you could get these patients transplanted quickly, that they would have outstanding results. And this resulted in the change in distribution of livers so that people with fulminant liver failure in the United States get priority for liver transplant. We were also a very early group to promote the notion of doing transplantation in HIV positive individuals. In the old days, that was considered to be heresy, but in fact, with improved advances in the treatment of HIV, many of the patients who were HIV positive were dying of liver disease or dying of kidney disease, and we demonstrated that you could do transplants safely in the HIV positive host. They have dysregulated rejection and immune response, but it's possible to do transplant in these patients. We showed that transplant could be safe. You had to modify the immunosuppression. We articulated which agents should be used in these patients, but it made a giant difference in the health of these patients. We were also one of the first groups to expand the criteria for doing liver transplant in patients with hepatocellular carcinoma. And what you're looking at is a CT scan with a tumor that's present in segment 6 of the liver, and we demonstrated that these patients, you could expand the criteria for doing transplants from what was the Milan criteria, relatively restrictive, to the UCSF criteria. So many more patients were able to have the life-saving liver transplant. We also demonstrated that you could take a large lesion, a large tumor, a large hepatocellular carcinoma, and make it smaller. And the patients in whom this treatment was done, the downstaging procedure, had just as good survival as patients who came initially for transplant. This is the survival data in these patients. One of the more interesting issues in transplantation was the observation that the liver could be divided into different segments according to its anatomy. I got involved with live donor liver transplant. So this is, I do the live donor operation. This is a photograph of a donor who's had his right lobe removed for transplantation into his small piece of liver that remains for live donor liver transplant. And this is a survival. We have used both left and right lobes for liver transplant after live donor liver transplant. And you can see that using either the left or the right lobe gives the same outcome. This is a photograph of a liver donor on the left. This is before the donation. And you can see that the left lobe on the right grows to the normal size once the person has donated their right lobe.
Dr. Nancy?
Yes.
Dr. Ascher, the presentation isn't, we can't see it right now.
Well, I don't know what happened. I can stop there and I can answer any questions that you might have. I was going to talk about my work in expanding roles for women. One of the problems in the United States in particular, but in your country as well, is that women are equally present in medical school, but they don't make it up higher after medical school. So when I was involved in being the chair, I was heavily involved with promoting women within surgery and then in faculty positions. But I'd be happy to stop here and answer questions if people have them.
Yes, we do. I had a question on my own regarding women and regarding you being the first female surgeon performing the surgery, the transplantation surgery. Was it accepted at first, or was it a bit strange for a woman to be performing the surgery?
So what I found was that when patients are sick, they don't really care if their surgeons are men or if they're women. They care about who can help them. And they saw that I could help them. So they became quite accepting of me. I think the patients were certainly a little bit more accepting than perhaps the older male surgeons, but they came around as well.
Have this helped other women, other graduates or people that are trained or working with you? Has this made them feel more empowered and they've had like a better chance at working?
So when I was the chair, half of the trainees, half of the residents were women. So that was fantastic. That reflected the number of people in medical school who were women. And when I was chair, 40% of our faculty are women. And so that's important too. But the issue of promoting women has to be a combined effort of both women and men. So we are reliant on our male colleagues to see that we can do the job too, and to embrace us to do the job. And the truth is, if we all do better, then it raises the bar for everybody. So I can't emphasize that enough.
Yes, definitely. Did you have to make any changes or succumb to any behavioral or changes of personality to become the person you are today, or you were because I remember for those of you who don't know, Dr. Nancy was featured in the 3rd episode for Surgeon's Cut, the Netflix documentary. The first sentence was that you were harsh and that you won't let anyone talk, or there was this certain harsh attitude with your residents or fellow colleagues. Where this attitude, has it been there all along, or did you have to have this attitude to be there, to how can I say this? Because some people would think in women are not harsh, or women need to put more effort to be there to have this place that you have right now. So do you need this harsh attitude working?
I think, well, I deal in a very serious field, and I think the patients appreciate the fact that I am serious about what I do. I think do we all change going into medicine? Do we all change when we see terrible things? We see wonderful things in medicine, but we see very terrible things too. And the way different people deal with that in different ways. Some people compartmentalize. Some people get more serious. Some people find relief or freedom in other ways. I have always been a serious individual. Did I become more serious doing liver transplants? Perhaps I did. But my patients tell me that they're delighted that I don't play music in the operating room and that I am serious about what happens to them. I feel like I can relax and laugh and smile and have jokes after we do the work, but not before we get the work done.
That's great. Does the stress affect your, like the intense work, the serious work in the operating room, does it affect your personal life? Can you do you turn off the stress and the intense work after the surgery, or does it stay with you for a while?
So I try to leave it at work. I try to leave work stuff at work and home stuff at home. I like to exercise. I do a lot of fitness work. I do meditation, and I try mindfulness. We instituted a program of mindfulness for the Department of Surgery because I think everybody has to learn to deal with this stress. And if you don't have a stressful career in surgery, I am surprised. You're very lucky. I mean, you're really, really lucky. But you have to figure out how to deal with stress because things don't always turn out perfectly. Even though we try as hard as we can, we don't always get perfect results.
You mentioned in the documentary that you work with your husband.
Yes.
Does this help balancing things out with your personal life, or does it make it a bit harder to separate your personal life and your work life?
Well, our personal life and our work life is all mixed in together, but I am fortunate because my husband's in the same field and he is my colleague, and I really trust him from a clinical standpoint as well as from a personal standpoint. So in that sense, it's quite helpful. But if you ask my kids, they heard about transplant at the dinner table practically every night, I would say. So maybe they have more to say about it.
I'm happy you always have the time to meet and stay together at the dinner table.
Yes, absolutely. That was one of the rules, right?
We have some questions from students and attendees. Someone is asking about the prejudice against female surgeons in the workplace. Is it getting any better, or is it still the same over the past years?
I think it's getting better. I mean, I can't speak for Egypt. I can speak for the U.S. And in the U.S., increasingly, so 20% of the practicing physicians, surgeons are women, but 40% of the trainees in the United States are women. So we are changing the demographics, and as we help each other and as we are increasingly present, we will be accepted. This train is going forward. It's not going backwards, and I see it happening in other countries as well. And I have to ask you what's going on in your country because every place is different, but you can make a change too.
Yes, we are making a change generally, especially this year. Not regarding medical students, but for demographics for the medical students here in our university, we have a lot of girls. I think it's around 40%. So we don't have a problem for medical students, but regarding the job opportunities or in workplace or the stigma that we have against female doctors, it's still there. Especially being our culture, we have this stigma more than other countries, but we're trying to work against this. But yeah, I can say we are moving forward too.
Good, yay! But that doesn't mean we want to. I mean, but we want to work with our male colleagues. I mean, it's not like we
Yes.
want a group of Amazons. We want everybody to have the opportunity to work together.
Yes,
That's what
exactly.
we're looking for.
Yes, we're all asking for them to just have the same opportunity, have the chance to work like our male colleagues.
Right, right.
Yes. Other questions regarding the transplantation itself. Someone is asking, do different lobes hold different purposes and different risks to being transplanted?
Say that again. Do different what?
Do different liver lobes have different risks, or are they have different functions for the transplant, or are they all the same?
Well, there actually is there's some remote evidence that the genes in one part of the liver are slightly different in terms of what's turned on. But functionally, the left lobe and the right lobe work equally well when they're transplanted into another host. So functionally, there isn't a difference. Clinically, there is not a difference.
Okay. Are you working on any specific research or like surgeries right now?
So what I'm concentrating on now has to do with global issues of fairness with transplantation. And of course, that's a really important issue in Egypt. So in the rest of the world, there is much more use of deceased donors. So people are not so reliant on using live donors. In Egypt, unfortunately, your medical groups only use live donors at the present. And that is okay, except it can put tremendous pressure on a live donor if they are reluctant to donate, for example, and they feel pressured by the family or pressured by the medical profession or pressured by society. There's also an opportunity for exploitation of those donors. So in some parts of the world, donors are actually paid to give one of their kidneys or give part of their liver. And that, of course, totally dehumanizes the human. You know, that is completely antithetical to our principles as physicians. So, you know, it's not supposed to be we're not supposed to commodify the body. We're not supposed to be able to pay for our organs. So that's a giant problem, and that's a problem I've been working on globally. I'm part of the WHO task force on transplantation, and I have been active in giving governments advice about what they need to do to set up sound transplant programs with adequate numbers of deceased donors as well as live donors. I'm a live donor myself, so I believe in live donation, but I think the person who's doing it has to be completely non-coerced and voluntary in that gift.
Definitely. How long have you been working with the WHO?
I've been working with them for the last 4 years.
And have you seen the success regarding your work, or is it still in the process?
Well, every country is different. So, and every country feels like their problems are unique to their countries. So, for example, in the Philippines, it's accepted, almost socially accepted for you to give money to somebody who might donate a kidney for you. Whereas in other countries, that's not acceptable. And when we think about, you know, universal ethics, the notion of buying an organ really should not be, I should not feel different about it than you feel about it in a different country. But we try to be sensitive to the issues. Now, I don't know why Egypt has been behind, I would say, in the development of deceased donation, but that they are behind. So we've got to help Egypt figure out why that is, and try to help them on the road to having more donors available. You know, liver cancer is really, really, really common in Egypt. So
Yes,
it's not
it
like
is.
you guys don't need transplants. You really need transplants. And you can't rely on live donors solely for your transplants.
We have the problem in Egypt because the religion and
Well,
the decisions and the medical decisions. So I think that's that's the problem.
I appreciate what you're saying. And of course, everyone thought that that was true for Iran. But Iran has a very robust deceased donor program because the Ayatollah actually set out a fatwa that donating after death was perfectly acceptable according to that Muslim interpretation. So I appreciate what you're saying, but I think we have to examine it a little further.
Yes. It will, I think the conflict will always, and especially in Egypt, I think we're working on it, but the conflict between science and religion is still a big part of the medical field and our community. When we're trying to fight it, we're trying to find like the reliable sources and have the best benefit for the patients. I think we're working on that.
Well, I hope that you're able to achieve it. In India too, there's heavy reliance on live donors and very little reliance on deceased donation. And again, there are numerous reports of people being exploited and organs being bought and sold. Giant problem.
That's a problem.
Yeah.
Someone is asking, how did you apply for the WHO? Were you recruited or did you volunteer? What their requirements?
So my position with the WHO, it's an unpaid position. I am a volunteer and part of the task force on transplantation, and I was chosen to do that. What they elected to do was have regional representation. So there are 2 people on the task force who come from North America. So within the WHO divides the world up into regions. So I'm a North American representative.
Another question: how are the advances in stem cell research affecting the field of organ transplantation?
So stem cell has the opportunity to have enormous impact in the field of transplantation, but we really haven't realized it yet. Although there is some information about our ability to grow cells onto do composite grafts that are partly human, partly based on stem cells, partly based on synthetic materials. For example, the larynx can be seeded with human cells, or the bladder, a neobladder could be seeded with human cells. So it has real potential application. It's hard to imagine how we would make it work for something as complex as a liver, though, building a new liver, although there is some information that the infusion of stem cells may help a failing liver or may help in the case of fulminant liver failure, but not the replacement of a whole organ yet.
Okay. Another question regarding the process of the transplant and the donor and the recipients. Are you involved in the decisions that are regarding the donor themselves, or are you like the doctor? You're in the operating room. You just follow up with the patient afterwards.
No. So my role is to help decide who needs a liver transplant, because I also do the recipient operation.
Okay.
I do all the live donor operations, so I decide who can be a donor, and then I take care of the patients during the surgery, of course, and then in the hospital after their surgery, and for the recipients, I care for them long term because I manage their immunosuppressive medications, the medicines that we use to keep them from having rejection. That's my job in the long term.
Is it hard regarding choosing the donor, having to take this decision? It's definitely not an easy one.
No, I think it's a really big, important decision. And yes, we want to make sure that the donors are acting of free will and that they really understand what they're getting into, and they really understand the potential risk, which could include death in a small number of donors who donate. I fortunately have never had that experience with any of my patients, but that is a possibility, and there have been reported deaths in donors in the world.
Do you believe you have this percentage of success because of the actual work, or is it because of your decision, or what are the factors that you depend on?
So I think part of the reason for success with both donors and recipients has to do with experience and has to do with how what the depth is of the team. So our group has been working together for the last 30 years, and we have very little turnover of doctors. It's the same group that, I mean, we have added new doctors as we've grown, but it really helps to have people with a lot of experience working with young people who can learn from that experience. So a lot of the programs who have had problems are newer programs who might not have had experience over years. But even experienced programs can have problems. These are major, major, major surgeries.
What do new doctors add to the table?
What do new doctors?
Yes, like the new doctors that work with you in the team.
Yeah.
What do they add based on they don't have the same experience that you do, for example?
So they have energy. They can question the paradigm. You know, that's really important for young people to say, yes, you've been doing it for 30 years, but maybe there's another way, a better way to do it. So we all have to recognize that new people bring new ideas, and that's exciting and potentially fantastic.
And you all accept those new ideas and you welcome them, or is it a bit hard to change your decisions or like how you work?
We all have to keep open-minded about new ideas. Having said that, we don't just embrace any new idea that just comes by, because that is, you know, potentially a harmful thing to do. But is to keep an open mind about it. And if somebody has a good idea, it doesn't matter if they're the most senior person on the team or the most junior person on the team. They have a good idea.
What advice would you give to the younger doctors, and especially the younger women and medical students?
Okay, so you can do anything you want. Absolutely, you can do anything you want. But you better make sure that you are well trained. You better make sure that you have chosen your mentors wisely. You don't have to have just one mentor. You can have multiple mentors. You can learn something different from many different people. You can also have peer mentors, which is important for reality testing. When, you know, it's easy to go out on a limb and you need a friend, let's say, or a mentor to tell you, you know, you're too far out. You've got to be good to yourself. You've got to, I talk about the idea that, you know, people write about you have to have balance in your life, or else you have to be used to imbalance. And I'm used to imbalance. I think women have a teeny bit of an advantage because we're used to multitasking and we're used to having a little chaos in our lives. It's okay.
Yes.
You know, we can live with that. It's not a bad thing. I also want to send the message that you can have a rich personal life and have a really good professional life too. You just have to figure out how to fit it all in. And you may not be able to fit it all in all the time, every single day, but you know, think about the big picture here.
How long did it take you to reach this balance?
I don't have balance. I have imbalance, but I'm okay with it. But I didn't start having children until I was 40. Because I was busy working on my career. I wasn't really ready emotionally or from a career standpoint to have kids, or even, emotionally, I guess. But now I have balance. I've figured it out.
I'm really happy to hear this, and I wish everyone finds this balance and balance soon. Someone is asking, would you be interested to work with students in Egypt, or regarding research or practice or any advice?
Sure, I'm happy to answer any questions that you have. I have a couple of mentees in Armenia. I have mentees in different countries who I have spoken with or talked to or emailed back and forth. I'm happy to do it.
How would people contact you using your email?
Yep, you have my email. You can pass it out.
Okay.
I gotta run.
Okay, Ascher. Okay, thank you so much. I'm so grateful to be here. I feel so empowered, and I'm sure everyone else feels the same.
I'm sorry that my slides cut off. I feel bad about that.
No.
Good luck to you all. Take care.
Thank you so much. Thank you.
Bye-bye.
Thank you. Goodbye.